بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the lecture number 6 in the series of Diagnostic Radiology in English, DRE, and we are handling the subjects of brain imaging. Now we will talk about the intraventricular lesions. As you all know, there are a lot of lesions that can occur inside the ventricles, and here are the main or the most common lesions we can see in the clinical practice, including the ependymoma, the choroid plexus papilloma, the meningioma, the subependymoma, giant cell, subependymal astrocytoma, and the neurocytoma. Then we have other lesions like most of the extraaxial cysts, like the arachnoid, the epidermoid, the dermoid, and the colloid cyst. They all can occur inside the ventricles. And some of the tumors like the medulloblastoma, astrocytoma, and metastatic deposits. Then how to know first that this lesion is inside the ventricle? We have certain diagnostic criteria, and we should ensure first that this lesion is an intraventricular lesion in order to go into the differential diagnosis. Then one of the easiest things is to see the lesion totally confined within the ventricle, like this tumor. You can see a homogeneously enhanced lesion totally located within the occipital horn of the left lateral ventricle. Then if you see a lesion that is known to occur inside the ventricle, like the colloid cyst, which occurs in the anterior part of the third ventricle, then other signs which will include the ipsilateral ventricle on the same side of the lesion is usually dilated, and there usually no evidence of brain edema because the lesion is usually isolated from the brain parenchyma by the wall of the ventricle. Then whenever the lesion is enlarged, it will in most of the cases take the shape or the configuration of the ventricle itself. Then look at these two lesions, and this is an intraventricular lesion with dilatation of the ventricle ipsilateral to the tumor and no perifocal brain edema in the adjacent cerebral parenchyma. While an extraventricular lesion is usually surrounded by perifocal brain edema, and it will compress the ventricle on the same side of the lesion. Then colloid cyst is a known lesion, and we have discussed it in the lecture of intracranial cysts. It has a characteristic location related to the anterior part of the third ventricle, and it usually shows high signal in T1 and T2 weighted images, and also shows hyperdense attenuation in the CT images. But as you remember, that the colloid cyst is usually diagnosed by its characteristic location in the midline plane anterior to the third ventricle, and it can show any signal behavior, either hypo or hyperintense in the T1 and hyperintense on the T2 weighted images. Then we'll start by one of the famous intraventricular tumors, which is the ependymoma, and the ependymoma represents about 9% of all gliomas, and it also represents 10% of the pediatric intracranial neoplasms, and is relatively more common in children than in adults, and this is the usual age of incidence, which is between 10 to 15 years. The ependymoma occurs inside the fourth ventricle commonly, and it also can occur at other locations like the filum terminal inside the spinal cord intramedullary, or it may occur in the supratentorial area. But the best prognosis or the bad prognosis is for that occurring in the posterior fossa. And this lesion will appear isodense to the brain parenchyma, filling the fourth ventricle. And if you inject contrast media, the tumor will show either homogeneous or heterogeneous enhancement. Being inside the fourth ventricle, obstructing the flow through the ventricle, the CSF flow through the ventricle, then you will get hydrocephalus in the supratentorial ventricles, dilated lateral and third ventricle, which is very common, a very common finding with ependymoma. Then the tumor may show cystic changes, which are seen in about 15% of the cases, and it is one of the common lesions that produce metastasis with CSF. And whenever you are diagnosing ependymoma, you should look for metastatic CSFC. Then this is a tumor which is classic for ependymoma. It's a midline posterior fossa specifying lesion centered to the region of the fourth ventricle. It shows homogeneous post-contrast enhancement with multiple areas of matrix calcification, as you can see. And calcium is very common in this particular type of the tumor. It may occur in about 40 to 50% of the lesions. Then the tumor is obstructing the fourth ventricle with consequent supratentorial hydrocephalic changes, as you can see in the dilatation of the temporal horns of the lateral ventricles. And this is a case of ependymoma, a tumor which is midline posterior fossa centered to the fourth ventricle region, and the supratentorial images showed multiple nodular enhancement in the basal cisterns as well as the quadrigeminal cistern, indicating a diagnostic of metastatic CSFC. Then ependymoma by MRI will appear iso to hypointense in the T1, hyperintense in the T2 weighted image, and after injection of contrast it will show similar pattern of enhancement like that of CT, which means that it may enhance homogeneously or heterogeneously. This is a T2 weighted image, and you see the tumor centered to the fourth ventricle, and this is T1 post contrast, and you see the enhancement of the lesion. This is also a good presentation of ependymoma by MRI. T1 weighted image, you see hypointense signal of the tumor. T2 weighted image, hyperintense signal of the tumor. And T1 post-contrast axial and sagittal images, where you can see almost homogeneous pattern of enhancement of the lesion. And very importantly, you can see that the tumor is almost obliterating the fourth ventricular lumen, and it has a specific character that the tumor can extend outside the ventricle through the fourth ventricular foramina. Then the subependymoma is a variant of ependymoma, which is a low grade, almost benign, let us say, benign neoplasm, and they may be asymptomatic. It does not produce CSF seedling. The tumor may occur in the fourth ventricle, but can occur also in the lateral ventricles. One of the most specific criteria of this subependymoma is that it does not enhance after contrast injection. And this is the FLAIR image, and this is T1 post contrast, and you can see the high signal of the tumor in the FLAIR and absence of contrast enhancement after injection of contrast media. This is a solid lesion, and no enhancement occur in more than 60% of the cases. It is a sharply defined lobulated intraventricular mass, and it may show some cystic changes, calcification, and also hemorrhage. This is T1 weighted image, and you see an intraventricular tumor in the right lateral ventricle of intermediate signal, and increased signal in the T2 weighted image after injection of contrast media, and you can see that the tumor does not show any pattern of contrast enhancement. Then look at this case where you can hardly see a lesion in the frontal horn of the left lateral ventricle. it shows intermediate signal in the T1, and you cannot appreciate the lesion in the T2 weighted image. And after injection of contrast, you can see that the lesion does not enhance. And this is the flare image, which will show the tumor of high signal compared to the dark signal of the CSF. And being the tumor does not show any pattern of enhancement, as I have said, and this is one of the supportive diagnostic criteria of the subependymoma. Then we came to the choroid plexus papilloma, one of the famous tumors occurring inside the ventricle, and it represents about 3% of all pediatric intracranial tumors, and most of these lesions occur in the pediatric age group before the age of 5 years. And the tumor arises from the choroid plexus, and you will know that the choroid plexus is responsible for CSF production. Then functioning tumors will increase the CSF production, and this will result in what's known as communicating non-obstructive hydrocephalus. Also, the tumor may obstruct the CSF flow because of mechanical obstruction or because of the hemorrhage. And this tumor, as you all know, is very vascular, and it frequently bleeds within the CSF spaces. Then the choroid plexus papilloma, about 25% of the lesions may show calcium and hemorrhage, and being a benign or almost a benign lesion, but it may show CSF seedling. Whenever you inject contrast media, it will show a strong heterogeneous enhancement. The strong enhancement because of the hypervascularity, and the heterogeneous enhancement because of the frequent areas of bleeding inside the tumor. Then this tumor has a characteristic lobulated surface, which is similar to mulberries. Then you see this classic appearance of choroid plexus papilloma occurring inside the ventricle, and you can see the marked dilatation of the ventricular system due to overproduction of the CSF flow of the CSF. Then this is, some of the choroid plexus papillomas do not secrete CSF, and then you will see only an intraventricular tumor with a lobulated surface, a strong enhancement, and you can see that the ventricles are not so much dilated. Then this is an appearance of the choroid plexus papilloma occurring in the occipital horn of the right lateral ventricle. The tumor usually shows a lobulated surface, and this edema is due to obstruction of the CSF flow in the occipital horn with retrograde backflow of the CSF in the adjacent brain parenchyma. Then whenever the choroid plexus papilloma has invaded the ventricular wall and extended outside the ventricle into the adjacent brain parenchyma, then you can consider the diagnosis of choroid plexus carcinoma. And this is a high-grade tumor, WHO3, and it has a high incidence of metastatic CSF seed. And sometimes it may be difficult to differentiate carcinoma from papilloma, especially if the carcinoma is totally confined within the ventricle. And this is the case of choroid plexus carcinoma that has invaded the ventricular wall and extended into the adjacent brain parenchyma with consequent perifocal brain edema around the tumor. And you know that resected choroid plexus papilloma will have a 100% 5-year survival rate, while the carcinomas will have only 40% 5-year survival rate. Then you remember that one type of the meningiomas is the intraventricular meningioma, which usually arise from meningeal rests within the stroma of the choroid plexus, as I have said before. And the most common site for the intraventricular meningioma is the trigone of the lateral ventricle, commonly the left one if compared to the right side. Then the imaging findings are those of a meningioma concerning the homogeneous enhancement, the smooth surface, the presence of matrix calcification. And multiple meningiomas are, as you all know, associated with neurofibromatosis type 2. And this is an intraventricular meningioma showing a smooth surface, homogeneous post-contrast enhancement, and this is the T2 weighted image showing increased signal of the tumor. 80% of intraventricular meningiomas occur in the trigone of the lateral ventricle, commonly on the left, and 15% occur in the third ventricle, and only half percent will occur in the fourth ventricle. Then sometimes you are not able to discriminate between choroid plexus papilloma, which does not secrete CSF, and an intraventricular meningioma. And all what is needed in such cases is just you mention that this is an intraventricular tumor, which may be a choroid plexus papilloma or maybe a meningioma. Then the diagnosis will be reached after surgery. And the differences between choroid plexus papilloma and intraventricular meningioma are as follows. The papilloma usually occurs in the children, while the meningioma occurs in middle-aged patients. The papilloma has a nodular lobulated surface, and the meningioma has a smooth margin. The papilloma is frequently associated with diffuse hydrocephalus because of the overproduction of the CSF and the mechanical obstructive effect. But the meningioma may have focal hydrocephalus obstructing the occipital horn of the ventricle only. The choroid plexus papilloma usually shows a heterogeneous enhancement because of the internal bleeding and areas of necrosis, and the meningioma will show a homogeneous pattern of enhancement. Then if you see a case like this is axial T1 weighted image, axial T2, and axial T1 post contrast. And you can easily diagnose that this is an intraventricular mass or an intraventricular tumor. And because of the absence of significant cystic changes, and this is an adult patient, then you may say that this is an intraventricular tumor, which may have the possibility of a choroid plexus papilloma or an ependymoma. And you know that ependymoma in adults will occur in the supratentorial area, while in the pediatric age group it is frequently seen in the region of the fourth ventricle. And this is a similar case, and you can see a tumor inside the right lateral ventricle. The right lateral ventricle is grossly dilated, no evidence of periventricular edema around the lesion, and the lesion showed a strong, almost homogeneous post-contrast enhancement. Then the diagnosis here is just an intraventricular tumor, which may be an ependymoma or an choroid plexus papilloma. Then you remember that this tumor, which is known as the subependymal giant cell astrocytoma, is a tumor which is frequently seen in patients with tuberous sclerosis. And you know that this tumor has a characteristic location in the frontal horn of the lateral ventricle. It shows homogeneous pattern of contrast enhancement, and it is diagnosed by the presence of the stigmata of tuberous sclerosis in the form of subependymal calcification in the wall of the ventricles. Then you know that MRI is less sensitive than CT in detection of calcium, but you can still diagnose the lesion by its characteristic location and enhancement in the frontal horn of the lateral ventricle. Then you came to one of the known intraventricular tumors, which is the central neurocytoma. And this central neurocytoma typically occurs in the lateral ventricle near the region of the foramen of Monro. This is a low-grade tumor, WHO1, grade 1. Then the incidence of the tumor is about 1%, and this lesion is characteristically seen in young adults. But look at this case. This is not a young adult, and he is complaining of headache, and you see a tumor inside the lateral ventricle. And you know that this tumor is inside the ventricle because of the appearance of the dilatation of the ventricle and all the criteria we have mentioned before. Inside this lesion, you can see foci of matrix calcification as well as cystic changes. And these cystic changes are helpful in the suggestion of this particular type of the tumor. The tumor will show heterogeneous enhancement. It has a high incidence of calcium in calcification and a very high incidence of cystic changes. And whenever you see a tumor inside the ventricle in a young adult patient with cystic changes within the tumor itself, then you think of this particular type of the tumor, which is a central neurocytoma. And this is an example, an intraventricular tumor in the left lateral ventricle. And this is T1 post contrast, where you can see enhancement, heterogeneous enhancement of the lesion. And this is the proton density, and this is the T2 weighted image. And here is the classic appearance of a central neurocytoma in the right lateral ventricle. This is T1 before contrast and T1 after contrast, and you can see multiple cystic changes as well as heterogeneous pattern of enhancement in this age group, and then you think of central neurocytoma. And then the neurocytoma is common in young adults. The central neurocytoma is common in young adults. It's a low-grade tumor, and it may contain calcium and cystic changes as well. Then you remember that dermoid cyst may occur inside the ventricle, but commonly it occurs in the subarachnoid space. And you remember that whenever you are diagnosing a dermoid cyst, you should look in the subarachnoid CSF spaces, because these lesions frequently leak fat within the subarachnoid space and also inside the ventricles. Then if you remember this case I have presented in the lecture of intracranial cysts, and you see dermoid cyst in the superior cerebellar cistern showing fat signal, soft tissue fat density, soft tissue densities, as well as foci of matrix calcification. Then the T1 weighted MR image showed the appearance of the fat of high signal, and you can see the fat CSF flow level within the frontal horns of the lateral ventricles due to leakage of this dermoid cyst into the subarachnoid space as well as inside the ventricular system. And this is a case of an intraventricular dermoid cyst. This dermoid cyst, which is made of fat, some calcium, and other soft tissues, is occurring inside the right lateral ventricle, which is dilated. Then look at the T1 weighted image, and you see the fat signal high in the T1, occupying most of the right ventricular lumen, and this is the T2 weighted image of the same case. Then you see this is a case of epidermoid cyst inside the fourth ventricle. You remember that epidermoid cyst will show low signal in the T1, high signal in the T2, and intermediate signal in the flare. And the epidermoid cyst will not show any pattern of contrast enhancement after gadolinium injection. And if you perform the diffusion weighted images, the epidermoid cyst will show restricted diffusion. Then subependymal metastatic deposits are diagnosed in patients known to have primary malignancy, and this patient is known to have a bronchogenic carcinoma with multiple enhancing nodules in the wall of the ventricle, diagnostic of metastatic deposits. And this is the case of multiple periventricular enhancing lesions in the wall of the ventricle, and surrounded by some degree of perifocal brain edema. And you remember from the lecture of the brain tumors that enhancing lesions periventricular in location may suggest the diagnosis of lymphoma. But also, if you know that this patient is known to have a primary malignancy, then you may suspect the possibility of metastatic deposits. Then you look at this case with this female patient is known to have breast cancer. Then in the T1 weighted image, you can see nodules in the wall of the ventricle, and these nodules have shown homogeneous enhancement. This patient had double primary. It has breast cancer and is known also to have lymphoma. Then, what do you think of these lesions? Do they represent metastatic deposits or lymphomatous deposits around the ventricle? We do not know. Then you may go to the clinical picture. You may have the help of spectroscopy, for example, and I don't know actually the way of treatment of such lesions, whether it is directed to the breast cancer or lymphoma or both conditions. And I thank you very much.